Okay. We're starting another 5 minutes, right, madam? Hello?
Yeah, 1 minute. We'll start 10 minutes we have. 10 minutes.
Okay, fine.
So you can close the window and go and do whatever you need to do. I think
Okay,
you're
okay.
busy
Great.
at work.
I'll come back in
Amma.
time. Yeah.
No problem.
Thank you.
Bye. We'll start 10 minutes we have. 10 minutes. Okay, fine. So you can close the window and go and do whatever you need to do. I think you're okay.
Hello, Nisha ma'am. Good evening. Good evening, Anand sir. Thanks for accepting to speak today. Nisha ma'am, we have gone live, YouTube live now already. Thank you.
Okay. But we will restart again in 10 minutes.
Okay,
No,
okay.
YouTube live now.
Hey, 10 minutes. It's not yet 8,
You can
right?
start when you want, ma'am.
Done.
Thank you.
Dr. Anand, Dr. Subbu. Dr. Subbu.
Hi, sir. Hello.
Dr. Subramaniam is IAP CCB secretary.
Okay. Hi, sir.
Anand. You both don't know each other, right? First time? Actually, I have not met Dr. Anand in person either. Dr. Errol was the one who first told us about.
Good to get to a lot of new people.
Correct. Yes.
Thank you, sir. Thank you for joining us today, sir.
Yeah.
So
I'll mute and we'll join again in about 8 minutes.
I'll come back in another 8 minutes back. Okay.
Done.
Thank you.
Thank you, sir. Thank you.
Just wait for a few minutes more and then we'll start. So, good evening, everyone. Welcome to IAP CCB's session for postgraduates. We've been holding this now. This entire year, we've been doing a series on perspective for pediatric postgraduates, the third part. The previous parts were done the previous years. And this is called Decoding Diseases. And this is our final session in December of this year. And we're very glad, we're very grateful to all of those who joined us earlier. I know you found it very useful. So for this last session of this year, we have a speaker, very happy to introduce Dr. Anand Tyagarajan. Dr. Anand Tyagarajan actually, he spoke with us earlier, 2022, I think. And he gave us this fantastic talk on radiology. So I thought we just have to have, now that we have our sessions also being recorded on YouTube, it's an excellent time for us to have excellent speakers speak to us with classes that are recorded. So welcome once again. Thank you, Dr. Anand, for agreeing to take this. Yeah, without any further delay, Dr. Anand Tyagarajan is the head of pediatric of radiology in Mehta Multi-Specialty Hospital. a graduate of Stanley and MMC, and also a consultant in other radiology centers across the city. So welcome, Dr. Anand. Thank you. I really enjoyed your talk last time. So looking forward to it this time.
Thank you, madam. Hello.
Yes, we can hear you.
Yeah. Hello and very good evening to everyone. I'm so much delighted to be amongst you on this lovely evening. May I take a moment to thank Dr. Nisha George for giving this wonderful opportunity to throw some perspective about pediatric imaging to all the young and budding pediatricians. If ever you were wondering what it takes a very good physician to become an excellent one, there has to be a few things, right? And one of the most important ingredient of that is having a good hold over the imaging itself. Almost all of the excellent physicians and surgeons that I've come across in my practice, I've noticed that they are all extremely proficient and seasoned in imaging. So it's certainly worthwhile to take some time off and learn as much of imaging as possible for all the young doctors. That's my piece of advice. With that, let me kick off this lecture for the day, which is going to be rather basic in its nature today. We're going to spend some time predominantly on the chest radiograph, which is obviously the most common investigation ordered to the radiology. We're going to see how to assess the film. We're going to see the evaluation of trachea, consolidations, atelectasis, etc. And we'll also be learning a bit about the foreign body injection and inhalations and lines and tubes. Never forget to check the radiograph itself before you start reading what is inside the radiograph. Always check the name, age, hospital ID, date, and it's a very good practice to compare and ask for the previous radiographs. How do you assess a film? You need to check whether the film is well centered or rotated, whether there's adequate inspiration, whether adequate penetration is there, and also check for the projection of the film. How do you check for the rotation of the well-centered film? Look at the spinous process of the spinous process, which is an exact midline structure of the body, and also look where the medial end of the clavicle is. If they are at equal distance, you probably having a well-centered film. Another way of looking at rotation is look at the length of the rib over here. If they are equal in length, probably it's a well-centered film. Now, what is the problem if this film is not well-centered? One problem is the trachea will be off its way, so it will be very difficult to make a comment on the location of the trachea. And the heart will be variable in size because of the rotation. And also that you'll notice that the lungs will be of different densities on each side just because of the rotation itself. So this has to be kept in mind. We all want a good inspired film, isn't it? A lung full of air when X-ray is done. How do you check for that? You have to count the anterior ribs, which come down like this. 1, 2, 3, 4, 5. And if you can see 5 ribs well above the level of diaphragm, you know you've got a very good X-ray on hand. What happens if it's not a good inspiratory film or an expiratory film turns out to be an expiratory film? You know, the lung itself will become white in color because it's less in air. And the heart will become larger in size because the diaphragm will be moving up here. Also that the basal regions will be very hazy. They're not opened up at all. So it'll be very difficult to make a comment on the lower zones of the lung. With regards to the penetration, this is purely at the hands of the technician who's handling the X-ray. How do you check for that? You have to look behind the heart. You have to see the vertebra. You have to be able to see the vertebra, just about able to see the vertebra, not too sharply though. And also that you can check for the left hemidiaphragm. It has to come all the way up to the vertebra. And this line you see over here is the left paraspinal line. If these lines are seen well, you know that you've got a good X-ray on hand. If it is underexposed, it's going to become hazy like this. You don't see the vertebra well enough. And if it's overexposed, you're going to see the vertebra far too well. You're even able to see the intervertebral spaces here. So this is an overexposed film. Also check for the projection of the film. Generally, this projection should be mentioned in the radiograph itself, but you also can make a quick check of it. If the clavicle is coming into the lung field like this, it will be a PA1. And on AP, the clavicle move out of the lung field. and the scapula will come into the lung field in AP, and scapula will move out of the field in PA. This is a quick way to check the radiograph, what projection it is. But what is the idea behind seeing all this quality of the X-ray itself? Is it to check whether it's a suboptimal image and just reject it? No, you're never going to get an absolute ideal X-ray at all. So the idea of learning the limitation of the X-ray on hand is to know how well it has been taken so that you don't call anything false positive or false negative. The trachea is a very flexible structure in pediatrics. They tend to buckle like this to the right side. It can buckle as sharply as this, 90 degrees like this. It's still fine, but no buckling to the left side is acceptable. This is because on the left side, the aorta is sitting there. So it's not going to allow the trachea to move to the left side. So trachea can buckle to the right side. That's good enough. As the buckling is happening, the trachea will also be moving anteriorly like this. So if you do a lateral X-ray, you'll find that this space is largely increased, the retrotracheal space, not to be alarmed at all. Some amount of tracheal narrowing is also acceptable at the subglottic level, as long as this tracheal narrowing is having this shape, which is that shouldering angle. So this is fine. This kind of narrowing is fine. What is not acceptable is diffuse smooth narrowing like this. That's problematic. That could indicate a laryngotracheobronchitis. Now coming on to the very common opacities that we see on X-rays, the atelectasis consolidations, both of them look increased in density, right? Atelectasis will be more homogeneous because there's no air bronchogram. Consolidations will have air bronchogram. And there will be, more importantly, volume loss in atelectasis leading on to movement of trachea, fissures, the mediastinum itself. And there would be compensatory hypertrophy of the hyperinflation of the adjacent lobe. Compensatory hyperinflation of the adjacent lobe. If there is atelectasis, these opacities can be triangular in shape many a times. Whereas in consolidation, there won't be any volume loss, no mediastinal shift. Here's opacity in the right upper zone. Looks a bit heterogeneous. You can see some lucencies here. Trachea is in the midline. This probably is the consolidation. Whereas this is looking more homogeneous. Trachea seem to be moving to the right side. Diaphragm is moving up. This probably is the atelectasis in the right upper lobe. Right upper lobe opacities have a characteristic finding because the lobe itself is more horizontally placed. Whereas left upper lobe takes a very different shape. The lobe itself is very vertically oriented. Therefore, you will get a diffuse homogeneous opacities like that. Also that the left upper lobe extends all the way up to this point. In fact, it covers the left heart border. So left upper lobe opacities will be diffuse like this. Here it is heterogeneous because of air bronchogram. Trachea is in the midline. Over here, it is more homogeneous and trachea is moving to the right side, to the left side. So this probably is an atelectasis and this a consolidation. Also to make note is that the left upper lobe lingular segment covers the left heart border. So here you can see the left heart border is getting obscured here. Right middle lobe consolidations. Anatomy to be noted is that the right heart border is covered by the right middle lobe and left heart border is covered by the lingular segment of the left upper lobe. Over here, you see opacity here obscuring or silhouetting the right heart border. So this is the case of right middle lobe consolidation. And if you do a lateral X-ray, you will find a triangular opacity like this because of the minor fissure over here and the oblique fissure below. Opacity in the right lower lobe. Here you see a triangular opacity here, obscuring the right hemidiaphragm. You can still see the right heart border well here. So which means that the opacity is in the right lower lobe. The mediastinum seems to be moving to the left, to the right. So it has to be an atelectasis. Over here, you see a more heterogeneous opacity, which is obscuring the right hemidiaphragm. Right heart border is well preserved. So this has to be a consolidation in the right lower lobe. Opacities behind the heart and the left lower lobe are the problematic one or difficult one to pick up. Here you see a dense opacity behind the heart, producing a double density. It's very obvious, right? It's easy to find out. But whenever you see opacities behind the heart, you have to check for these two lines that I mentioned earlier. One is this left hemidiaphragm, and this one, the left paraspinal line. An opacity in this part of the lung will obscure these two lines, as it is seen here. So you don't see the left hemidiaphragm or the left paraspinal line here. You know for sure there is an opacity. But many a times opacity is not this obvious, right? Like in this case, you don't see a definite opacity, but surely the left hemidiaphragm is obscured, the left paraspinal line is obscured, and some haziness is here. So surely something is happening over there. So whenever you check for the left low lobe opacities, look for these lines, you'll be more sure what's happening there. And if you still have a doubt, you can do a lateral radiograph. This is a normal lateral radiograph where it's the lung opacity is seen and the vertebra will be seen very well. Whereas if there's an opacity, it will become hazy like this. What is even more simpler is do an ultrasound. You'll see very clearly a consolidation. Ultrasound is extremely sensitive in picking up consolidations in the lung. These are the air bronchograms. Another example of opacities in the left lower lobe. Here, it seems to be some opacity sitting here. Heart is moving to left. So surely probably a atelectasis is happening in the left lower lobe. But when we did a CT scan, we found there's a large collapse of consolidation. Huge one, not a small one. So the point to remember is that this part, it's a lot submerged behind the heart and the diaphragm. So a smaller opacity means, in this case, actually turns out to be a very big one. So the point here to remember is that radiographs can underestimate the size of the consolidation or the atelectasis itself, because one, it is hidden behind the heart. Another one, significant amount of lung actually extends below the dome of diaphragm. It's not here that the lung ends. The lung actually goes much below this. So there will be a lot more disease than what we make a guess of at times. When there is a consolidation, lobar consolidation, which expands the lobe and displaces the fissure like this, what we call as bulging fissure sign, it's more often because of Klebsiella pneumonia as being the cause. Okay, now, what is lobar pneumonia? What happens in lobar pneumonia? Lobar pneumonia starts in the alveoli and spreads from one alveoli to the other through the collateral paths, right? So it continues to spread until the entire lobe is involved. But it will be confined to one lobe because it does not spread past the fissure. So lobar pneumonias are one that are confined to one lobe, and they might have air bronchogram. They're usually bacterial in etiology, and certain bacteria are known to be associated with lobar pneumonias. On comparison to that, bronchopneumonias start in the bronchus as bronchitis, then move on to the peribronchial region as inflammation, then starts involving the airways. It then starts involving the alveoli. So the possibility of this involving multiple areas in the lung is very high. Therefore, you will see this bilateral multifocal patches in bronchopneumonia. This differentiation we try to make because bronchopneumonias are known to be more severe, and they're known to be caused by gram-negative bacteria or Staph aureus or fungi even. So this differentiation should be made on a radiograph. Whereas viral infections generally involve the interstitial spaces, not the alveoli, not the airway. They tend to involve the interstitial spaces. That's why you start getting these perihilar or peribronchial thickening like this without air bronchogram. You don't expect to see air bronchogram or effusion in viral infections. Now, what happens in viral bronchiolitis? Since these bronchioles are so small in children, when they get inflamed, they tend to occlude and leading on to trapping of air distally. So you don't actually see the bronchial wall thickening or the small nodules that come up in bronchiolitis on an X-ray. You rather see the trapping of air distal to that. So the lung could become far more translucent like this. You could see some flattening of diaphragm like this. These could be the indirect signs of viral bronchiolitis. And if you happen to do a CT, you will see these areas. These are the mosaic perfusions. These are normal lung densities, and these are areas with air trapping. So you get this mixture of different densities, what we call as mosaic perfusion. And you might see this peribronchial thickening or inflammation like this. And you could also see these branching dots, what we call as screen bud opacity. This is also the same one we get in tuberculosis also. So these are the subtle findings that you might see on a CT scan if you happen to do it. Now, if there is a large pneumonia and you're suspecting a necrotizing pneumonia, the only way to confirm that is by doing a contrast enhanced CT, where you will see a hypodensity here. This is a normal enhancement of lung. So these non-enhancing areas mean that they are all in liquefactive necrosis. So these are definite signs of necrotizing pneumonia. Interestingly, ultrasound is also very sensitive in picking up these necrotizing changes. If you do an ultrasound, you find these dark areas clearly depicting necrotizing changes. This is one peculiar type of pneumonia that you see in children alone. This is a lobar pneumonia, which is, as it is trying to spread into the entire lobe, it gets confined to a sphere because the interalveolar communications are not well developed in the children. So this is a peculiar pneumonia that you see only in children probably less than 5 years old, round pneumonia. Here is the consolidation with a thick-walled cavity, more commonly seen in tuberculosis or Staph aureus. Over here, you see some thin-walled cavity here. This is a nematocele seen in Staph aureus or Klebsiella infections. But it's important to make this difference because cavitating pneumonias are active lesions, whereas nematoceles are lesions which are self-resolving. They might be seen even for several weeks after the infection is settling down. So if there is a doubt in differentiating between these two, we may have to do a CT scan where you will see a thick-walled cavity like this with surrounding consolidation with cavitating pneumonia. There is a thin cavity with regular wall, smooth inner wall with little haziness around. We'll see that in nematocele. So on a radiograph, it is possible to differentiate atelectasis from consolidation, which could be an important thing to do because a very big atelectasis could be because of a mucus plug sitting in the main bronchi, and removing that bronchi could ensure very fast recovery. So knowing whether it's a pure atelectasis or a consolidation is a useful information to gather. It is possible to differentiate lobar and bronchopneumonias for obvious reasons because bronchopneumonias are known to be more severe infection. If you want to establish a complicated pneumonia, you need a contrast enhanced CT. And a radiograph generally underestimate the quantum of disease in the lung itself, especially in the lower lobes and on the left side. CT scan will tell you exactly how much of lung is involved. Now, differentiating viral and bacterial pneumonia continues to be a challenge radiographically. Coming on to pleural effusion, the fluid gets collected in the dependent part of the lung, isn't it? In an erect posture, it happens to collect in the bottom of the lung. And the first thing it does is it blunts this costophrenic angle. This is the lateral costophrenic angle. Just mark this word. It's a lateral costophrenic angle. And then when more fluid gets collected, it also blunts the cardiophrenic angle. This is the cardiophrenic angle, right? And then it goes on to produce a concave upper margin, what we call as the Ellis curve. But the problem is, for this little blunting of the costophrenic angle, a lot of fluid needs to get collected. In an adult, we need at least 200 ml for this blunting to happen. So this is not a very sensitive, is not the most sensitive sign to pick up early effusions. If you want to pick up smaller fluid, you may have to do a lateral radiograph. What you see here is the posterior part of the costophrenic angle. What we saw on the frontal X-ray is the lateral costophrenic angle. This is the posterior costophrenic angle, which is more dependent than the one we saw earlier. So this is going to pick up smaller quantum of fluid, right? So here's this blunting. This could pick up much less amount of effusion. And the most sensitive radiograph to pick up the least amount of fluid is a lateral decubitus like this. You have to put the patient on one side, and then all the fluid will gather to the bottom, and you will pick up the least amount of fluid on this one. But what is more sensitive and the best way to pick up the least amount of effusion is an ultrasound. Ultrasound can pick up as little as 3 to 5 ml of fluid over here. This is the effusion. So among all the investigation, ultrasound is the most sensitive to pick up the least amount of effusion. Ultrasound can also differentiate a clear effusion from an infected pleural fluid with all these septations over here. These indicate that this effusion is infected. Now, how does an infected pleural effusion look on a radiograph? It doesn't get this concave upper margin like the clear fluid. Because of the fibrinous adhesion, it starts developing these convex margins in different places. It can be anywhere in the chest. So these kind of loculations mean that the effusion is infected. But in a supine X-ray, we're not going to get this blunting of costophrenic angle or the meniscus or the Ellis curve. What we're going to get is the fluid is going to get accumulated behind the lungs itself. So you won't get this blunting of costophrenic angle. What you'll see is a homogeneous increase in opacity. And compared to this side, you see that the entire pneumothorax seems like opacified. That's what you'll get in a effusion. And if you watch more closely, you will see fluid tracking into the minor fissure. You see some fluid near the apex, and you'll also see some fluid along the costal margin. These are the signs of effusion in a supine posture. That's what we are going to get more often in pediatrics, isn't it? That's the appearance of effusion on a CT scan. This concavity, this is the equivalent of the Ellis curve. You get this concavity in effusion. And when that fluid gets infected, or when that effusion gets infected, you get these loculations, this loculated pleural effusion. But if you want to clearly differentiate an effusion from an empyema, infected pleural fluid, you need a CECT where you'll see that the pleura is thickened. This is the parietal pleura, this is the visceral pleura. This splitting is called the split pleura sign, and you find the fluid inside. Whereas in a clear effusion, the pleural layers are very thin. So you can clearly make this differentiation between empyema and effusion only on a CECT. Now coming on to the mediastinum, let's start with the hilum. The hilum could be prompting us with something really sinister happening deep inside. So we need to watch the hilum a little carefully. Here you can see that this is a normal hilum. This is an abnormal one. This one is obviously bigger, more denser, and looking more lobulated. So this means that some lymph nodes are sitting in this hilum. But how do you ascertain those smaller ones, the earlier or the smaller lymph nodes? The three things that you have to watch out for. One is you have to look at the size of the hilum. Another one, you need to see the density of the hilum, and then the shape of the hilum itself. If you just compare these two, the size of the hilum probably more or less the same. And the density, probably this is a little bit more dense than this. But what is more sensitive, important to look for is the shape. Shape in the sense, if you look at the lateral margin here, you see there's a concavity there because the normal bronchi and the pulmonary arteries, which happen to occupy the hilum, they tend to branch as they move outwards. So you will have a concave lateral margin, whereas if it's a lymph node, you will get this convex margins here. Then you start suspecting that something is going on. And once you suspect, it's important to do a CT scan and make sure there's no lymph nodes, major lymph nodes sitting there. Also, the right descending pulmonary artery is a prominent vessel that you'll see in all patients on the right side, not to be mistaken for a lymph nodal lesion. These are examples of big hilar lymph nodes. This is another hilar lesion, which appears very smooth wall. There's actually enlarged pulmonary arteries because of pulmonary hypertension. Now, the reason for hilar enlargement could be infections like tuberculosis or fungus. Even sarcoidosis can produce bilateral hilar lymph nodes. Enlargement of the pulmonary arteries could be the cause of enlarged hilar lesions. And it could be as worse as malignancies like lymphomas, and carcinomas can also be seen as hilar bulge. Now, moving on to the mediastinal lesions itself. Mediastinal lesions generally have a convex lateral margin like this, and the medial margin will merge with the mediastinum. And this margin will be very, very sharp. That's the typical characteristic of a mediastinal lesion. Compare that with this one. This is also a convex lesion laterally, but if you see, the margin is very fuzzy, not very sharp. This is a case of a lung lesion leaning onto the mediastinum. Unlike here, this is very sharp. Just watch the sharp lateral margin, which means that the lesion is coming out from the mediastinum. There are a few normal structures to become aware of to pick up those little lesions from the mediastinum. One is the right paratracheal stripe. Right paratracheal stripe, which is the white structure that you see here between the tracheal air column and the lung air column. This white sheet is the right paratracheal stripe. This is a very sensitive structure. This normally measures around 4 to 5 millimeters normally. And if there is a lesion right next to it like this is a normal right paratracheal stripe. And if you see a little bulge there, you have to suspect probably a lymph node there. Another important area to look for early lymph nodes is there's a convex bulge here. That's the aortic arch. There's another convex bulge here. That's the pulmonary artery. And you see this dip here, small depression. That is the aortopulmonary window. That concavity should be maintained in all cases. Over here, that concavity is gone, right? It's become a little bulge here. So which means that something is happening over here. You suspect a lymph nodal enlargement. Also, you have to, these two lines that we talked about while discussing about left lower lobe lesions, the hemidiaphragm and the left paraspinal lines, these also will become submerged if there is a lesion arising from the mediastinum. So you have to watch out for these lines too. The bigger masses from the mediastinum, here is a large lesion in the mediastinum, appearing very dense with sharp lateral margin, which appears convex. When we did a lateral radiograph, it disturbed this is a normal retrosternal lung density, which is missing here, confirming that's a mediastinal lesion in the anterior mediastinum. Over here, a sharp convex lateral lesion. We did a CT, we found a cystic lesion closely applied to the trachea, turned out to be a bronchogenic cyst. Another convex lesion, this time from the left side of the mediastinum. Can you see that merging with the left paraspinal line here? This line is coming up to this point and then it is disappeared, which means that this is close to the vertebra. We did a CT, notice that the lesion is posteriorly placed close to the bones, turned out to be a neurogenic tumor. Thymus in infants can become very big, can seem very big and confuse us with mediastinal lesions, but it has a certain appearances and shapes which we need to become familiar with to not mistake them for mediastinal lesions. It can have this triangular outgrowth like this with a sharp margin limited by the minor fissure, what we call as the Sage sign. Compare that with the convex opacity of a mediastinal lesion. This is a typical appearance of thymus. It has got many other appearances too, but generally it is a low density structures. So therefore, you will see the pulmonary vessels going behind them. Unlike in a mediastinal lesion, you don't see anything behind them. So this is another way to make sure we're only dealing with a thymus. Thymus is a bilobe structure. It can grow to big sizes. Like in this case, it has become so big that it is occupying the entire mediastinum. It is even covering the heart, producing a cardiothymic silhouette, and it even can reach up to the diaphragm, this thymus. Thymus is very soft in consistency. It doesn't disturb the surrounding structures. In fact, the surrounding structures can make their mark on them. Like in this case, the ribs are making an impression on them, producing this wave-like appearance, this one. Where the thymus meets the heart, you will get a little notch there, which means that it is only the thymus and not any mediastinal mass. If still there is a doubt, the easiest way is to do an ultrasound. You'll find this homogeneous, scattered, hyperechoic foci, what we call as a starry sky appearance. It's very easy to confirm it is only thymus. See, this thymus is just so pliant, it's just going between the vessels, not disturbing any of the surrounding structures. So we can confirm thymus with ultrasound for sure. Moving on to pneumothorax, collection of air in the pleural cavity. In an erect posture, air will collect laterally and the lung will collapse medially. That's how it happens. And you will see the visceral pleura. You need to see this thin line of visceral pleura and this area of increased radiolucency without any lung markings. Now, these are the signs of pneumothorax in an erect posture. But it is not so obvious many a times, right? You need to look at this case, for example, from a distance, this hemithorax looks little bigger and darker. If you watch closely, you can see this thin line. You need to see this visceral pleura for sure to call anything as a pneumothorax. You see increased radiolucency here without lung markings. Now, this appearance can be seen better if you ask for an expiratory film. An expiratory film helps in increasing the size of the pneumothorax, and then it helps us to see it better. So asking for an expiratory film in suspected pneumothorax makes sense. But what we get in pediatrics is generally a supine radiograph, right, to detect pneumothorax, not the erect one. So what are the signs of pneumothorax in a supine posture? You might see just a diffuse increased density of the hemithorax. You might not see the visceral pleura anywhere. You might just see diffuse increased opacity like this, or you might see radiolucency along the epiphysis like this. Unlike on the right side, you see these dark areas. This could be a sign of pneumothorax. Or you can see that the costophonic angle could become much more deeper. Compare that to the normal one here. It's far more deeper and darker, what we call as the deep sulcus sign. Or there could be dark areas in the base of the lung fields, air collecting below the level of the lungs. Or the air could collect between the dome of diaphragm and the anterior costophonic angle, producing double diaphragm. You can see two shadows here, one here, one here. This is the double diaphragm sign of pneumothorax in supine. Even more sensitive is this. You will see this cardiomediastinal seal out here as sharply like this, unlike here where it is merging with the lung. If you see this sharp black line, you probably can suspect pneumothorax. Most sensitive method is to get a cross-table lateral view as the child is lying in supine. You see that air collecting anteriorly here. It's lining the thymus here. You can see that air is nicely collected at the top of the chest. But the problem with this is we won't know which side the pneumothorax is in this case. Whereas if you do a lateral decubitus, on the suspected side, air will collect on top and lung will go down. So when the air is a lot, it starts pushing the mediastinum to the left, right? Like this. So this is tension pneumothorax. A larger tension pneumothorax even displaces the diaphragm down, mediastinum all the way to the left. And you can see this irregular lucency. These are all pulmonary interstitial emphysema. Now, this is tension pneumothorax can cause vascular compromise because they can compress all the large vessels in the mediastinum. It has to be addressed promptly. Just a moment, please. Please give me a moment. I'm trying to show a video. Are you able to see this video there? Hello? Hello?
Yes, 1 minute. Can we tell?
Yeah.
I can see
I'm
that.
trying to,
Yes.
I'm trying to show an ultrasound video.
Oh,
One point.
you're not able to show?
Yeah, just a minute, it's coming up.
Oh.
Dr. Anand, it played actually. So
Yeah,
can
it
you
played, yes.
Just a minute. Coming. It'll keep on. I'm sorry. Yes, madam. You can see that white line moving up and down. That is the pleura moving with the chest wall, what we call as the lung sliding sign. If this is present, for sure there's no pneumothorax at this place at least. That's the point I want to make. So ultrasound is very sensitive in picking up pneumothorax also, but you need to see this lung sliding to make sure there's no pneumothorax. Once you don't see this lung sliding, you start suspecting pneumothorax. Okay, it's a part. Okay. 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 Okay, I'm back here. I'm sorry for the interruption. So moving on to, so that's a point I wanted to make, that ultrasound can be put to use to detect pneumothorax. And moving on to ingestion of foreign bodies. Now, one of the commonest ingested foreign body is a metallic coin, isn't it? When you see a coin like this on a frontal X-ray, the first question on mind is whether it's in the esophagus or in the trachea. Now, if the coin is facing you like this on a frontal X-ray, it means that probably it is in the esophagus. If you want to make double sure about that, you do a lateral X-ray, you will find the laryngotracheal air column over here. And normally the esophagus is placed behind the trachea. So the coin is also sitting there. So that's a way to confirm it is sitting in the esophagus only. On the contrary, tracheal coin will be in profile or sideways on a frontal X-ray and will be facing you on a lateral X-ray. Compare that to the esophageal coin. Now, what do you do with the coin? Coin is rather inert in some sense, so it can be absorbed in the esophagus for up to 12 to 24 hours. Once it reaches the stomach, you can even wait up to 3 to 4 weeks. Coins bigger than 25 mm are unlikely to pass through the pylorus, so you may have to remove them. But most of the coins generally pass through spontaneously via naturalis. So a radiographic follow-up once in a week should be good enough. It's absolutely important to differentiate a coin from a button battery because the management and the outcome are completely different. So whenever you see a coin shadow in a radiograph, always make sure that you go closer and see if there is a peripheral halo like this, which would mean that it is a button battery and not a coin. Or on a lateral X-ray, if you might see a beveled edge like this. So that's the reason why we sometimes ask for a AP and lateral view in foreign body injections for these signs, because making this differentiation is absolutely imperative, because the button batteries are known to cause thermal injury because of the corrosive nature, and they can be catastrophic if left in the esophagus for many hours. So if it is seen in the esophagus, has to be removed on an emergency. And if it reaches the stomach, you can observe for about maximum 48 hours. It has to be moved otherwise. And if it is past the stomach, you can follow it up radiographically. Now, with regards to the sharp objects, obviously anywhere in the esophagus or the stomach up to the pylorus has to be removed out. In the esophagus, it becomes an absolute emergency because the possibility of perforation. Now, the long objects are also problematic. By definition, the ones that are more than 6 centimeters in big children and 4 centimeters in smaller children are called as longer objects. These also have to be removed promptly from the esophagus, because even though they're not sharp, they're known to perforate the surrounding structures simply because of the size. This was an example where a long object from the duodenum, these long objects struggle to pass through the curve of the duodenum. So what happens is they come out of the duodenum and start piercing surrounding structures. Like in this case, this structure has gone into the right kidney. So this had to be removed. So the longer structures generally have to be removed from the stomach. Magnets are other peculiar objects to handle. Solitary magnets can be managed conservatively with serial radiograph. But if there are multiple magnets, then that becomes a problematic one, because these magnets tend to clog with each other. In the process, they also trap the bubble loops between them, which then can go for necrosis or perforation, fistula, or even sometimes obstruction. So when you see one magnet, it's very important to see whether there are multiple magnets. That has to be looked at closely. And once past the stomach, all these foreign bodies, you're going to follow them up clinically and radiographically, looking for signs of obstruction like this, multiple fluid levels, which means there's obstruction, or in the signs of perforation where you'll see air under the diaphragm. But if the patient is supine and looking for air, there could be increased radiolucency like this over here. And you'll see the falciform ligament coming up like this, which is the football sign. So you basically look for increased radiolucency in the upper part of the abdomen. Or if you are intended to pick up little air in the abdomen, you can do a lateral decubitus where the air will, you have to do a left lateral decubitus because the air will connect under the abdominal wall and the liver. This is a very sensitive radiograph to pick up the little air. Now, ingested fishbone ingestion is another problem. Most of these get stuck in the oral cavity or in the oropharynx or around the tonsillar fossa. But if they get past that, once they enter the esophagus, they usually get arrested near the cricopharynx, somewhere here. And unfortunately, not all these fishbones are visible on a radiograph because they are not very dense material. If you're lucky, you might see a thin streak of opacity like this. And generally, we go in for a fiber optic nasoendoscopy to see whether there is an obstructing lesion and also to remove that. But if you're not doing that, or if that turns out to be negative, you can do a CT scan. It is much more sensitive in picking up those little bones. But if the presentation is very late, an X-ray can pick up indirect signs of fishbone. You might not see the fishbone itself, but you'll see this widening of the prevertebral space, and you can see this glass locules. These are indirect signs that a fishbone has stuck there and is complicating the situation. Now, the question is, what is widening of the prevertebral space? The thumb rule is, this is a normal X-ray here for you. This distance is a prevertebral space, and this is the vertebra itself. This length should be less than this length. That's a thumb rule. That's how you quickly assess whether there is thickening of the prevertebral space. Obviously, this has become more than this, right? So it means that this widening of the prevertebral space, and you have to search for the fishbone. So what is the advised radiographs in suspected foreign body ingestion? An AP and lateral radiograph of the neck, chest, and abdomen, which means the entire gastrointestinal tract must be looked for from nasopharynx up to the anus. Button batteries, multiple magnets, sharp objects, long objects, all need to be removed promptly. If any of them get beyond the stomach, you need to serially follow them up with radiographs. If they're stagnant or show signs of obstruction or perforation, even if they don't, if they don't move forward and get stagnant, you have to remove them. Important to make a note that never miss multiple foreign bodies, because sometimes when you see one foreign body, you stop with that. There might be another one further below. And the most important fact to remember is not all foreign bodies are radiopaque, right? There are many glass structures or plastic structures which might be absolutely not seeable on a radiograph. That has to be kept in mind. Foreign body inhalation is certainly a very life-threatening condition, isn't it? It has to be promptly identified and treated. But unfortunately, these are the ones which are more difficult to find, because most of the inhaled foreign bodies are organic substances like nuts or seeds, which are not radiopaque. They're very small, and these can get clogged in the larynx or in the trachea, but many times they get stuck in the bronchus. And if you watch closely, this bronchus is actually overlapping with the heart and the bony structure. So you don't see the bronchus itself very well. So the chances of seeing a foreign body sitting in the bronchus on a frontal X-ray actually is very less. If you're lucky, you might see a foreign body sitting in the right bronchus like this, but not very commonly seen. But therefore, an oblique view of the chest might help in seeing that sometimes. But what we should seek for is the secondary signs of an obstructing inhaled foreign body, which is that if the bronchi is getting obstructed, you will see the air trapped in that part of the lung. So you have to search for any asymmetry in the lung density. And if you do an expiratory film, you'll actually accentuate this difference, and you may see it better. So an expiratory film is very handy in picking up the air trapping. Now, how do you do an expiratory film in a pediatric child? It's pretty easy. All you have to do is ask the attendant to press the abdomen as the X-ray is being done. You'll get an expiratory film. So you will exaggerate the finding and you'll be able to see the air trapping better. So that's the difference between an inspiratory and expiratory film. You can see that the left lung has changed a lot during inspiration and expiration, which means that this lung is working normally, whereas the right lung is pretty static in its behavior, which means that it is obstructed. You can also try and do a lateral decubitus view on both sides. When you do a lateral decubitus, what happens is the mediastinum, because of its weight, will fall down on the lung and the lung will recoil and become smaller. This is the normal behavior. Now, in this case, the lung is stiff. It's not responding to the weight of the mediastinum, which means that the possibility of air trapping somewhere here. So once you know that the lung is obstructed, there's obstructive emphysema, you know that something is happening there, and you can ask for the bronchoscopy, which will confirm whether there is anything obstructing there and also help in removing the same. So what is the advice of radiographic series in foreign body inhalation? Neck, AP, and lateral imaging, because you have to see from the nasopharynx. And inspiratory and expiratory chest radiograph will be very handy. Lateral decubitus chest radiograph if possible. If you have fluoroscopy, that also can be useful because that is a live X-ray. You can see the breathing movements live. Now, this was an interesting inhaled foreign body. There's a definite history of foreign body inhalation, but the chest X-ray was absolutely normal. There's no air trapping, there's no emphysema. but there was this new onset of wheeze in this child. So we had to go in for a CT scan, and we found this interesting foreign body sitting in left main bronchus. Can you see that here? This structure is like this, open on both sides. It's actually the distal part of a ball pen, where there's opening on both sides. So there was no complete obstruction. Air was moving in and out, but there was this partial obstruction causing wheeze. Then it had to be removed. This is that foreign body. Moving on to lines and tubes. Let's see how those have to be checked. Nasogastric tube has to come down in the midline, go past the tracheal bifurcation, go below the level of diaphragm, and it has to go and rest under the left hemidiaphragm and not pointing towards, it has to go and rest under the hemidiaphragm like this and not come and point to the right side like this. This means it's sitting in the pylorus. Here it is sitting in the body of the stomach. This is more optimal for operation. Some examples of abnormal placement of NG tube. Here it has gone and coiled into the tracheobronchial tree. Over here, it has gone all the way into the right lower lobe. And if you continue to feed, you will develop a big consolidation. Over here, the tube has stopped short here. Obviously, need to push them further down. Here is a Ryle's tube that's coiling up in the upper chest with a distended air-containing area. No gas bubble, likely esophageal atresia without tracheoesophageal fistula. Now, if in the same case you find air in the stomach, it probably means esophageal atresia with the distal tracheoesophageal fistula. Now, complication when inserting NG tube is very, very rare, but if they do occur, they can be catastrophic. They're very deadly. Perforation of the esophagus can cause leak of air into the mediastinum and into the subcutaneous planes. So in this, if there is a perforation, if you do a neck X-ray, you'll find gas in the left side of the neck usually. Or if the air moves into the mediastinum, it will lift the thymus on both sides, what we call as the Spinnaker sail sign. This is a definite sign of pneumomediastinum secondary to esophageal injury. Nasogastric tube can also be seen very well with an ultrasound. Over here, you can see the tube. Can you see that? This is the esophageal tube in the neck region. This is the thyroid gland. And we are seeing this in the neck region. And then going to the subcostal region, you can see the tube over here. There's a liver, there's a stomach. So you can see the NG tube with ultrasound also. The endotracheal tube placement, where we want to place it, we want to place it between the thoracic inlet and the carina. That's where we want to place it, somewhere in the middle, right? Now, where is thoracic inlet? The most definite landmark for that is the first dorsal vertebrae, not the clavicle. Clavicle can move with different positions of the arm itself. So we should know where the first dorsal vertebra is. This is the first rib. Where it goes and attaches, that is the first dorsal vertebra. So you know for sure where the first dorsal vertebra is. The trachea generally lies between D3, D4, and D5. Okay, so if you keep the tube tip below D2 and D3, generally you're safer. Here's an example. That's D1. That's D2. This tip is coming just below the level of D2. And trachea and the carina is seen somewhere here. What you want is at least about 1.5 to 2 centimeters away from the carina. This distance should be at least 1.5 centimeter because the tube itself will move with the movement of the neck. That's to be kept in mind. That's why you need to include the mandible while doing a radiograph to check the ET tube, because we need to know whether the neck is in neutral position or is in a flexed position. If the neck is in a neutral position, this mandible will correspond to C5. Here, this is C7. Okay, this is D1. So mandible is coming up to D7, which means the neck is in flexion. The tube has come to D1, D2, D3, D4, somewhere between D3 to D4. So it is moved down actually because the neck is in flexion. So we need to know the position of the neck So kindly include the neck also while doing the chest radiograph. It might be very helpful. Look, for example, in this case, this is the D1, this D2, the tip is somewhere in the middle of D2, and over here it is moved. This is D1, so it is gone on the top of D1 now, right? Not a very safe position. You can see that the tube is moving up and down with movement of neck. Okay. Some abnormal placements of the tube. Here the endotracheal tube has come all the way down and hitting the carina. This is not advisable too because this can stimulate sympathetic activity. You want to keep that distance between the carina and little above that. Over here, the tube has gone all the way into the right main bronchus, ventilating the right lung well, causing complete collapse of the left lung. Over here, the tube has gone into the right main bronchus, hyperventilating the right lung, causing pneumothorax, so much so, and the left lung is in complete collapse. This tube has gone straight down, not gone through the passage of trachea or bronchi. It is actually going along the path of the esophagus, well below the level of carina, right? Carina will be somewhere here. And also that the stomach and the esophagus will air filled. So this is actually an endotracheal tube in the esophagus. Right. This is the first dorsal vertebra, and your tip is at C6 level, right? This is C7. This is D1. The tip is at C7. Now, this is risky. You don't want it to be there. It is not even below the thoracic inlet. There's high risk of, unintended extubation in this case. You need to keep the tip of the tube below this point, somewhere close to this point. So whenever you're checking for the ET tube position, try to include the mandible so that you'll know what the position of the neck is at that point of time. Moving on to the central venous catheter, the aim is to keep it in the superior vena cava, right? The superior vena cava lies somewhere here, right? Somewhere in this part, right? On the right side of mediastinum. What is the landmark? It actually, this is the first rib, this is the first costal margin. SVC actually starts here and goes up to this, up to the third anterior costal margin. So this is the landmark for the SVC. And you can see the carina here. So basically the SVC extends from above the carina, goes below the level of carina, right? That's the landmark for the SVC. From first costal cartilage till third costal cartilage, right? So your aim is to keep the tip somewhere here. Okay, this is the right IJV inserted central venous catheter. You can see the carina here. This tip is lying above the level of carina, just above the level of carina. This is okay for short-term usage of the catheter like fluid administration or pressure monitoring and all. But if the intention is for long-term chemotherapy or a longer duration usage, it has to go. This is the carina. This tube should go below the level of carina to reach the cavo-atrial junction. That is the junction between the SVC and the right atrium. You need to get close to that point. But always the tube should be vertically down like this. And if the aim is dialysis, you can take the catheter all the way into the right atrium because you need that high flow for blood return and replacement. So it's safer to keep the tube into the right atrium itself when it is for the purpose of dialysis. This is a right IJV catheter coming and slanting to one side. We don't want this. We want all the time the catheter to be vertically down. Now, what is the problem with this kind of slanting one side is the chances of infections, thrombosis, all that happens only when the catheter is not parallel to the wall of the SVC. This is a left-sided inserted central venous catheter coming into the brachiocephalic vein and stopping there. Obviously, you need to push it to this point. This is a subclavian via inserted catheter coming into the brachiocephalic vein, entering the SVC, all right, but it's more horizontally placed, right? You want that to be vertically down like this. This is an improper positioned catheter. Over here, you see the catheter coming up here up to that point and then looping here, because that's entering the azygous vein. That's where the azygous veins comes and joins the SVC. Over here, left IJV catheter coming and entering, looping in somewhere here, probably the intercostal vein or the hemiazygous vein. Over here, the left side catheter takes the completely wrong course, going into the left subclavian vein instead of going into the brachiocephalic vein. Now moving on to umbilical catheters, the two of them, one the umbilical arterial and the umbilical venous catheters. Umbilical venous catheters usually will be on the right side, artery will be on the left side, as corresponding to the aorta and IVZ in the abdomen. Another one is the venous catheters. After entering the umbilicus, will just straight head towards the heart, whereas the arterial catheters, after entering the umbilicus, will loop down, come down into the pelvis, enter the iliac vessel, and then go up. So that's the feature with difference in the behavior of these two catheters. If you do a lateral X-ray, you'll find that the venous catheters is much more anteriorly placed, whereas the arterial catheters will go posterior along the vertebra. These are the normal course of these catheters. Now, where do you appropriately place the venous catheter? The umbilicus venous catheter has to go and end here, just at the level of diaphragm. Just at the level of diaphragm, or just a little above that, where the IVC and the right atrium are meeting up. That's the exact place where you keep the umbilical venous catheters. The umbilical venous catheter has to go through the umbilical vein first, and then it has to cross the portal vein in the left portal vein in the liver. Then it enters the ductus venosus, and then the IVC, and then the right atrium. So it does have a very arduous path to go through. So the chances of stumbling and moving in different directions is very, very high for the umbilical venous catheter. In this case, the umbilical venous catheter, after going through the umbilical vein, entering the left portal vein, takes a turn to the right and enters the right portal vein. So this is an example of intrahepatic placement of the umbilical venous catheter. And over here, the umbilical catheter takes turn to the left and enters into the left lobe of the liver. Over here, it is shot a little bit too much. Instead of being in the IVC, it has gone into the right atrium itself. This has to be pulled back a little bit. Or this is far too much. It has gone into the right atrium and then into the SVC all the way up. So this has to be pulled back. An intrahepatic placed catheter, the problem is it can cause portal vein thrombosis, portal vein rupture, and even can cause liver hematoma or necrosis. If you watch closely, you see some lucencies here, which means that there's some air pockets within the liver parenchyma secondary to portal vein thrombosis. If you do an ultrasound, you'll find liver necrosis secondary to intrahepatic placement of umbilical venous catheters. Now, how about the umbilical arterial catheters? Umbilical arterial catheters, after entering the umbilicus, comes down, gets into the iliac arteries, then goes up in the descending abdominal aorta, right? The idea is to keep them between D6 and D9. Now, this is D12, right? There's a 12th rib, you can see it there. So this probably is D10 and this is D9. The tip is just above D9. This is very safe. This is where you should keep the catheter tip. This is D9, this is D6. So you want to keep it somewhere between that. That's the area where you want the tip of the catheter to be. Not here. The reason being, all the major vessels of the abdomen, like the celiac artery, superior mesenteric artery, inferior mesenteric artery, and renal arteries all arise between these places. You don't want this catheter to go and meddle with those major arteries. So you want to keep it above the level of D9 and below the level of D6. This is placed a little lower. Can you see it is below the level of D12? Not a very safe place. We may have to push it up. But this has gone far too much, right? This arterial catheter has gone all the way into the up to the level of D3. This is D1, D2, D3. where you'll find the aortic arch. This catheter has gone into the aortic arch itself. And this enthusiastic catheter has gone all the way into the left subclavian artery, one of the branches of the arch of aorta. There's a problem. These vessels can go in for spasms, so you better pull it back as quickly as possible. Now moving on to the intercostal drainage catheters. Intercostal drainage catheters, these are inserted for the sake of draining pneumothorax and pleural effusion, starting at the mid-axillary line. But if the aim is to drain pneumothorax, the catheter should point up like this and anteriorly, more to the anterior aspect of the chest, and the tube should be pointing towards the head. And if the aim is to drain pleural effusion, the tip should point down, preferably posteriorly, along towards the posterior aspect of the chest. Some examples of improper positioning of the ICD. An improper position or an obstructing catheter can cause subcutaneous emphysema like this. Or an intrapulmonary catheter can cause pulmonary hemorrhage like this. Over here, the catheter has gone all the way into the mediastinum itself. It's always a good practice to see the size of the heart. Sometimes there'll be massive cardiomegaly. In that case, the person who's inserting the catheter must be aware of that. It's important, as when you insert the catheter for pneumothorax, it's important to keep the tip below the level of third rib. You don't want to go and poke the apex like this, because that is where the sympathetic trunk is running. And when you go on and disturb them, you might develop neurological complications like Horner syndrome. So some take-home points over here. Always aim for a good inspiratory film in all ambulatory patients. Expiratory films are requested in pneumothorax and foreign body inhalations. Lateral chest X-ray is more sensitive in picking up smaller effusions, even more effective as an ultrasound. Watch for these small lateral convexities in the hilum to pick up those small lymph nodes. When you do a chest X-ray, check X-ray for ET tube, try to include the mandible to know exactly where the neck is at that point. When you do a radiographic series for foreign body, evaluate from the nasopharynx up to the anus. When you're checking for pneumothorax in supine radiograph, look for radiolucencies along the lung bases and adjacent to the heart and mediastinum. Ultrasound is extremely useful for detecting effusions, consolidations, and many, many more. Yes. Thanks for everyone. Is that time done?
Yeah, that's super time. Thank you very much, Dr. Anand. I'll just read a question. One of the questions that came here. Great session, sir. Kindly clarify risky foreign body length greater than 6 centimeters by 4 centimeters or width greater than 2.5 centimeters. These measurement criteria are real time or in X-ray film?
See, the length is 6 centimeters for bigger babies and 4 centimeters for smaller babies. The age is not clearly defined. The length has to be measured on the radiograph. Now, these days, all the radiographs are digitalized, right? So the scale will be there in the equipment itself. You can measure the exact size on the computer. Okay, so that measurement is what to be taken. And width more than 2.5 centimeters is also a problem because they don't go through the pylorus. So if there's a coin which is more than 2.5 centimeter, it's unlikely to pass through the pylorus. So both have to be considered. If any one of them is increased, I think we have to remove it. No way.
I had a question too. In these foreign bodies in when they cross into the stomach and intestine, so how do you identify based on how do you identify the position? Is it in the stomach, small intestine?
Yeah, that's a challenge, madam. On a plain radiograph, whether it is in the stomach or in the transverse colon, sometimes it confuses us. Sometimes a lateral radiograph might help, but that's always a challenge. We don't know because on a radiograph, everything is overlapping. It could be in the stomach, it could be in the transverse colon. Both will look very similar on X-ray. So that's a bit of a challenge, frankly speaking. That's why these serial radiographs will give the answer. If it is static, we know that it is stuck in the stomach more probably. Once it passes, usually the bodies move very fast.
Correct. Okay. So you're saying that it's difficult to identify whether it's stomach or small intestine at that, or large intestine at that time. Colon.
Yes, that was very difficult. We're not definitely sure many a times. It's possible to say with certainty, but then nobody can be dead sure about that. A CT scan might help.
Okay. Are there any other questions? You can just unmute and ask. So, Dr. Anand, the other members of CCB today on this are Dr. Lakshmi Prashanti, Dr. Priyavartani, Dr. Subramaniam. I'll ask them to open their videos. Thank you very much from all of us for our concluding session of this. It's on YouTube, so anybody's participants here, I think the great benefit is that we can go back and look at them again. So thank you very much.
Thank you. Thank you.
I think good
Thank you,
night.
Dr. Anand.
Okay.
I think we'll close it.
I'd say bye.
If there's anything, yeah.
Yes.
And considering the fact that this is the last PG program for this 2024 IAP CCB, I think I should thank all the EB members and the OB members of IAP CCB and all the seniors and colleagues and the postgraduates for taking active participation in this PG program and really making it a success. The success of this program is not just based on the numbers who attend during the program. It is also based on how many people are able to review these programs for a period of time in YouTube and keep watching it at their own pace and learn at their own pace. I would also our gratitude to all the faculties, including Dr. Anand today, who have taken time of their busy schedule to actually contribute so much to learning and teaching. Thank you, sir. Thank you all. I think as the year comes to a close, we should pat ourselves in the back and try and see if we can do better next year also. Thank you all. Happy New Year to everybody. Thank you, sir.
Happy New Year to all. Thank you.
Thank you. Thank you. Thank you.
Thank you.
Ah, yes. Thanks.
Thanks. I'll end the meeting, Nisha.